Hello, this is Dr. Morris. I'm continuing with the lecture series for the respiratory system. This is Respiratory System Part 4, and we'll complete the lecture series on the respiratory system. We've talked about the other mechanisms involved in respiration in the previous lectures. Today I'd like to talk specifically about the homeostatic mechanism of respiration. As you recall, homeostasis refers to a steady state. And this steady state begins at a cellular level, continues at an organ level, and obviously affects the system, the human system as well. As far as the lungs are concerned, if lung diffusion rates at the peripheral or the alveolar capillaries becomes unbalanced, homeostatic mechanisms intervene to restore equilibrium. Such mechanisms involve changes in the blood flow and oxygen delivery that are regulated at a local level, and changes in the depth and rate of respiration under the control of the brain's respiratory centers. The activities of the respiratory centers are coordinated with changes in cardiovascular function, such as fluctuations in blood pressure and cardiac output. The rate of oxygen delivery in each tissue and the efficiency of oxygen pickup at the lungs are largely regulated at the local level. For example, if peripheral tissue becomes more active, the interstitial levels of oxygen will fall and the CO2 levels will rise. This change increases the difference between the partial pressures in the tissue in the arriving blood, so more oxygen is delivered and more carbon dioxide is carried away. In addition, the rising levels of CO2 will cause relaxation of smooth muscles in the walls of the arterioles and the capillaries in the area, increasing local blood flow. Local factors that help coordinate this include lung perfusion, or the blood flow to the alveoli, the alveolar ventilation, or airflow over a wide range of conditions and activity levels. As blood flows toward the alveolar capillaries, it is directed toward lobules which the relative levels of CO2 are high. This movement occurs because alveolar capillaries constrict when the local areas of oxygen are low. Such a shift in blood flow tends to eliminate temporary differences in the oxygen and carbon dioxide level contents of the alveoli, the lobules, and groups of lobules that could be otherwise result in minor variations in local blood flow. Smooth muscles in the walls of bronchioles are sensitive to the concentrations of O2 and CO2. When CO2 goes up, the bronchioles increase in their diameter, referred to as bronchodilation. When the CO2 declines, the bronchioles constrict, referred to as bronchoconstriction. Airflow is therefore directed to the lobules which the CO2 levels are high. Because their carbon dioxide is obtained from the blood, these lobules are actively engaged in gas exchange. This response is especially important because the improvement of airflow to functional alveoli can at least partially compensate for damage to the pulmonary lobules. By directing blood flow to alveoli with low levels and improving airflow of alveoli to high levels, local adjustments improve the efficiency of gas transport. When activity levels increase and the demand for oxygen rises, the cardiac output and respiratory rates increase under neutral control, but the adjustment in alveolar blood flow and bronchial diameter occur automatically. Respiratory control has both involuntary and voluntary components. Your brain's involuntary centers regulate activities of respiratory muscles and controls respiratory minute volume by adjusting the frequency and depth of pulmonary ventilation. They do so in response to sensory information arriving from your lungs and other portions of the respiratory tract, as well as from a variety of other sites. The voluntary control of respiration reflects activities in the cerebral cortex that affect either the output of respiratory centers in the medulla oblongata and the pons, or motor neurons in the spinal cord that control respiratory muscles. The respiratory centers are three pairs of nuclei in reticular formation of the medulla oblongata and pons. The motor neurons in the spinal cord are generally controlled by respiratory reflexes, but they can also be controlled voluntarily through commands delivered by the corticospinal pathway. Now, I recognize we have not gone into depth on the neurovascular system at this point. We will cover that later in this semester. However, it is important to recognize that these voluntary commands come through the nervous system, specifically through the corticospinal pathway. There are paired centers in the medulla that set pace of respiration. Each center can be subdivided into two groups, and this is important: the dorsal respiratory group, DRG, and the ventral respiratory group, VRG. Dorsal referring to the back, ventral referring to the front. The VRG functions only during forced breathing. It includes neurons that innervate lower motor neurons controlling accessory muscles of respiration involved in active exhalation, the expiratory center, and maximal inhalation, or the inspiratory system. If you don't recall the accessory muscles of respiration, I recommend you review that, also covered in the respiratory chapter in your textbook. The DRG inspiratory center contains neurons that control lower motor neurons innervating the external intercostal muscles and the diaphragm. The DRG functions every respiratory cycle, whether quiet or forced. Again, you should focus on understanding the principle of the DRG, the dorsal respiratory group, and its function in innervating the external intercostal muscles and the diaphragm, which are the primary muscles involved in respiration. DRG and VRG have reciprocal inhibition. There is reciprocal inhibition between the neurons involved in inhalation and exhalation. When the inspiratory neurons are active, the expiratory neurons are inhibited, and vice versa. The pattern of interaction between these groups differs between quiet breathing and forced breathing. During quiet breathing, activity in the DRG increases over a period of 2 seconds, provided stimulation to the inspiratory muscles. Over this period, inhalation occurs. After 2 seconds, the DRG neurons become inactive. They remain quiet for the next 3 seconds and allow inspiratory muscles to relax. Over this period, passive exhalation occurs. This illustration is from your textbook, demonstrating the cycles involved in both the inspiratory and expiratory phases of inhalation. As you can see, in quiet breathing, the process involves dorsal respiratory group being active, inspiratory muscles will contract, thus inspiration will occur. The dorsal respiratory group becomes inhibited after 2 seconds, and then inspiratory relaxation will occur, passive expiration occurs, and then the cycle process starts over again. In forced breathing, you see a similar cycle also demonstrated on this illustration. This is out of your textbook. During forced breathing, as the level of activity in the DRG increases, it stimulates neurons of the VRG that activate the accessory muscles involved in inhalation. Again, you should know the accessory muscles of respiration. At the end of each inhalation, active exhalation occurs as the neurons of the expiratory center stimulate appropriate accessory muscles. The basic pattern of respiration thus reflects a cyclic interaction between the DRG and the VRG. The pace of interactions is thought to be established by the pacemaker cells that spontaneously undergo rhythmic patterns of activity. Attempts to locate the pacemaker, however, have been unsuccessful in research. The central nervous system stimulates the central nervous system stimulants such as amphetamines or caffeine increase the respiratory rate by facilitating the respiratory centers. These actions are opposed by the central nervous system suppressants such as barbiturates and opiates. One of the reasons why we see medications such as aminophylline, which is a xanthine, very closely related to caffeine, which is a stimulant, will affect and improve a person's breathing. Medications such as theophylline and aminophylline are used in patients with respiratory diseases such as asthma or chronic obstructive pulmonary disorders. The apneustic and the pneumotaxic centers basically involve the pons. The pons is a portion of the brain. Again, I recognize we have not studied the nervous system yet, but I do encourage you to go to the neurological section of your textbook and at least identify this region of the brain referred to as the pons. Again, the amnestic center and the pneumotaxic center both are located there. And they are paired nuclei that adjust the output of the respiratory rhythmic centers. The activities regulated are that regulate the respiratory rate and the depth of respiration in response to sensory stimuli or input come from the centers of the brain. Each amnestic center provides continuous stimulation to the DRG on the side of the brainstem. During quiet breathing, stimulation from the amnestic center helps increase the intensity of inhalation over the next 2 seconds. Under normal conditions, after 2 seconds, the amnestic center is inhibited by signals from the pneumotaxic center on that side. During forced breathing, the amnestic center also responds to sensory input from the vagus nerves regarding the amount of lung inflammation or inflation. Now, if you recall, the vagus nerve we talked about a little bit earlier in another portion of the respiratory lecture. The vagus nerve is a strong parasympathetic nerve. Remember, there are two autonomic nervous systems, the parasympathetic and the sympathetic system. The vagus nerve is a primary sympathetic, the vagus nerve is primarily a parasympathetic nerve. The pneumotaxic center inhibits the amnestic center and promotes passive and active exhalation. Centers in the hypothalamus and the cerebrum can alter the activity of the pneumotaxic center as well as the respiratory rate and depth. Essentially, normal respiratory cycles continue even if the brainstem superior to the pons has been severely damaged. If the inhibitory output of the pneumotaxic center is cut off by stroke or other damage to the brainstem, and if sensory innervation from the lungs is eliminated by cutting the vagus nerve, the person inhales a maximum capacity and maintains a state for about 10 to 20 seconds at that time. Intervening exhalations are brief and little pulmonary ventilation occurs. This is an illustration taken from your textbook that demonstrates the CNS regions involved in respiratory control. The higher centers, which include the cerebral cortex, limbic system, and hypothalamus and its location. There is the pneumotaxic center, the pons, and the amnestic center that I have talked about earlier. As you can see, there are chemoreceptors and baroreceptors that are located in the carotid and aortic sinuses. We'll go into more detail about the chemoreceptors and baroreceptors when we revisit the circulatory system, which will begin in the next lecture series. There are also stretch receptors in the lungs that sense the volume of inhalation or exhalation that occurs. There are motor neurons which control the diaphragm. Again, these come from nerves located in the cranium. Cranial nerves 3, 4, and 5 typically innervate the diaphragm. There is the dorsal respiratory group, which I've also mentioned earlier, and the ventral respiratory group, DRG and VRG respectively, which control respiratory rhythmicity in the centers. Interactions between the DRG and the VRG establish the basic pace and depth of respiration. The pneumotaxic center modified the pace. An increase in a pneumotaxic output quickens the pace of respirations by shortening the duration of inhalation. A decrease in the pneumotaxic output slows the respiratory pace but increases the depth of respiration because the amnestic centers are more active. Again, I would review this illustration. Again, this is taken from your textbook. I would expect you from this illustration to be familiar with the location of the pneumotaxic and the amnestic centers located here in the pons. I would expect you to recognize that motor neurons control the respirations of the diaphragm and the intercostal muscles. I would expect you to understand and note the location of the dorsal respiratory group and the ventral respiratory group, again controlling respiratory rhythmicity centers. You should also appreciate the higher centers located in the cerebral cortex, the limbic system, and the hypothalamus. This will help you later on when we discuss the neurological system as well. Now, there are certain respiratory reflexes. The activities of the respiratory center are modified by sensory information from several sources throughout the body. Information from these receptors alters the pattern of respiration. The induced changes have been called respiratory reflexes. Chemoreceptors sensitive to pH or blood are in the cerebrospinal fluid. Changes in blood pressure in the aortic or the carotid sinuses. Stretch receptors that respond to changes in the volume of the lungs. Irritating physical or chemical stimuli in the nasal cavity, larynx, and bronchial tree, and then other sensations including pain, changes in body temperature, and abnormal visceral sensations. There are specific disease processes that can affect these areas of the lungs. Sudden infant death syndrome, also known as crib death, kills an estimated 10,000 infants each year in the United States alone. Most crib deaths occur between midnight and 9 a.m. in the late fall or the winter and involves infants 2 to 4 months old. Eyewitness accounts indicate that sleeping infants suddenly stop breathing. They turn blue and then relax. There seems to be some genetic factors associated with this disorder, but controversy remains as to the relative importance of other factors such as laryngeal spasms, cardiac arrhythmias, upper respiratory system infections, viral infections, and central nervous system malfunctions. The age and the time of death corresponds with the period when the pacemaker complex and the respiratory centers are establishing connections with other portions of the brain. It has recently been proposed that SIDS, which is the acronym for sudden infant death syndrome, from a problem in the interconnection process that disrupts the reflexive respiratory pattern. The respiratory centers are strongly influenced by the chemoreceptor inputs from the cranial nerves 9 and 10 and from the receptors that monitor the composition of the cerebrospinal fluid. The glossopharyngeal nerve, or cranial nerve number 9, carries chemoreceptive information from the carotid bodies adjacent to the carotid sinus. The carotid bodies are stimulated by a decrease in the pH of the blood. Because changes affect pH, our receptors are indirectly stimulated by a rise in the levels of CO2. The vagus nerve monitors chemoreceptors in the aortic body near the aortic arch. These receptors are sensitive to the same stimuli as the carotid bodies. Carotid and aortic body receptors are often called peripheral chemoreceptors. Chemoreceptors are located on the ventrolateral surface of the medulla oblongata in the region known as the chemosensitive area. The neurons in the area respond only to pH of the CSF and are often called central chemoreceptors. Stimulation of these chemoreceptors leads to an increase in the depth and the rate of respiration. Under normal conditions, a drop in PO2 has little effect on the respiratory center until the arterial PO2 drops at about 40% to below 60 millimeters of mercury. If the arterial blood PO2 drops to 40 millimeters of mercury, the level of peripheral tissue, the respiratory rate will increase by only 50 to 70%. In contrast, a rise in 10% of the arterial PCO2 will cause the respiratory rate to double, even if the PCO2 remains completely normal. Carbon dioxide levels are therefore responsible for regulating respiratory activity under normal conditions. That's a very important statement. Carbon dioxide levels are therefore responsible for regulating respiratory activity under normal conditions. Although the receptors monitor levels are more sensitive, oxygen and carbon dioxide receptors work together in a crisis. Carbon dioxide is generated during oxygen consumption. When oxygen concentrations fall rapidly, levels are usually increasing. This cooperation breaks down under unusual circumstances. For example, you can hold your breath longer than normal by taking a deep breath. full breaths, but the practice is very dangerous. The danger lies in the fact that increasing the ability to hold your breath is not due to extra oxygen, but to a loss of carbon dioxide. You literally blow off CO2 by taking in a deep breath before you hold your breath. If CO2 is driven down far enough, your ability to hold your breath can increase to a point which you become unconscious in the oxygen starvation in the brain without ever feeling the urge to breathe. Chemoreceptors as such are subject to adaptation, a decrease in sensitivity after chronic stimulation if the or remains abnormal for the extended period of time. This adaptation can complicate treatment of chronic respiratory disorders. The example given relates to diseases such as chronic obstructive pulmonary disease or emphysema. If these levels remain low for an extended period of time and remains chronically elevated, the chemoreceptors will reset to those values that will oppose any attempts to return to partial pressure to the proper range. So remember, in conditions such as emphysema or chronic obstructive pulmonary disease, our drive to breathe is based upon our CO2 levels. In patients with chronic illnesses such as this, the patient's CO2 level chronically over time becomes elevated, and where a normal CO2 level may be 36 to 40 millimeters of pressure in a normal individual, patients who suffer from chronic obstructive pulmonary disease have a chronic elevation in the PCO2 level to levels of around 50. If you give these patients oxygen, it will drive their PCO2 level down to a level of about 30. But the stimulation to breathe is based upon the CO2. And so if their CO2 level typically is at 50, which is their drive to breathe, and with oxygen you drove their CO2 level down to 30, this person will stop breathing. So the use of oxygen in a patient with chronic obstructive pulmonary disease or an emphysema has to be gauged carefully to ensure that you don't take away this individual's drive to breathe. Because chemoreceptors monitoring the levels are sensitive to pH, any condition altering the pH of blood in the CSF can affect respiratory performance. For example, the rise in lactic acid levels after exercising causes a drop in the pH that helps stimulate respiratory activity. Hypercapnia and hypocapnia. An increase in the arterial blood CO2 constitutes hypercapnia. You need to know that definition. A decrease in arterial blood CO2 constitutes hypocapnia. A rise in arterial PCO2 stimulates chemoreceptors that accelerates breathing cycles in the inspiratory center. This change increases the respiratory rate, encourages the loss of CO2 in the lungs, and lowers PCO2. A drop in arterial PCO2 inhibits these chemoreceptors. In the absence of stimulation, the rate of respiration decreases, slowing the rate of CO2 and elevating arterial PCO2. The following slide illustrates the changes in PCO2 and the adjustment made in the respiratory system to maintain homeostasis. Again, you can see our focus is on homeostasis, looking at disturbances in homeostasis. Increased arterial PCO2, which refers to hypercapnia, you get an increase of PCO2 in the CSF, you get stimulation of the arterial chemoreceptors, stimulation of the CNS chemoreceptors, which will stimulate the dorsal respiratory group, which in turn will increase the respiratory rate. This increases the elimination of CO2 at the alveoli. You get decreased arterial PCO2, homeostasis is restored. Again, another mechanism which demonstrates homeostasis being disturbed, decreased levels of PCO2. You get inhibition in arterial chemoreceptors, you get a decrease in PCO2 in the CSF, the CNS chemoreceptors are thus stimulated, and reduced stimulation of the CNS chemoreceptors. I'm sorry, I stated that wrong. Reduced stimulation of the CNS chemoreceptors. You get reduced stimulation in the dorsal respiratory group, which in turn promotes decreased respiratory rate, decreased elimination of CO2 at the level of the alveoli, thus increased arterial PCO2, and homeostasis is restored. Again, I would appreciate this illustration. This is taken out of your textbook, but following through and being able to write out the steps of this homeostasis mechanism, where we see disturbed homeostasis and then the accomplishment of maintaining homeostasis by a series of mechanisms, not only helps you to understand the functioning of the chemoreceptors and their location, but also the effects of the nervous system related to the dorsal respiratory group. And though the illustration doesn't point out the ventral respiratory group, you can see, especially when we talk about decreased levels of PCO2, that if we have reduced stimulation in a dorsal respiratory group, obviously the ventral respiratory group would be activated. So know this illustration. The slide also illustrates central response to hypercapnia, which triggers the stimulation of chemoreceptors in the carotid and the aortic bodies, and reinforced by stimulation in the CNS chemoreceptors. Carbon dioxide crosses the blood-brain barrier quite carbon dioxide crosses the blood-brain barrier quite rapidly, so rising arterial levels of CO2 immediately elevates in the CSF, lowering the pH of the CSF and stimulating the chemoreceptor neurons of the medulla oblongata. The chemoreceptors stimulate your respiratory center to increase the rate and depth of respiration. Your breathing becomes more rapid, more air moves into and out of your lungs at each breath, and because more air moves into and out of the alveoli each minute, alveolar concentrations of carbon dioxide decline, accelerating the diffusion of carbon dioxide out of the alveolar capillaries. Thus, homeostasis is restored. The most common cause of hypercapnia is hypoventilation. In hypoventilation, the respiratory rate remains abnormally low and is insufficient to meet the demands of the normal oxygen-carrying carbon dioxide. Carbon dioxide then accumulates in the blood. If the rate and depth of respiration exceed the demands of oxygen delivery and carbon dioxide removal, the condition of hyperventilation exists. Hyperventilation will gradually lead to hypocapnia and abnormally low PCO2. If the arterial PCO2 drops below normal levels, chemoreceptor activity decreases and the respiratory rate falls. This situation continues until it returns to normal and homeostasis is restored. The output from the carotid and aortic baroreceptors also affects the respiratory centers. When blood pressure falls, the respiratory rate increases. When blood pressure rises, the respiratory rate declines. This adjustment results from stimulation or inhibition in the respiratory centers by sensory fibers of the glossopharyngeal, cranial nerve number 9, and the vagus nerve, cranial nerve number 10. Now, the Herren-Bauer reflexes are named after a physiologist who described this in 1865. Sensory information from these reflexes distributed in the apneustic centers and the ventral respiratory group. The Herren-Bauer or Herren-Brewer reflexes are not involved in normal quiet breathing or in tidal volumes under 1,000 cc's. The inflation reflex prevents overexpansion of the lungs during forced breathing. Stretch receptors are located in the smooth muscle tissue around the bronchioles and are stimulated by lung expansion. Sensory fibers leaving the stretch receptors of each lung reach the respiratory rhythmicity center on the same side via the vagus nerve. As lung volumes increase, the dorsal respiratory group is gradually inhibited and the expiratory center of the VRG is stimulated. This goes back to the illustration we looked at earlier. Inhalation stops as the lungs near maximum volume and active exhalation then begins. The deflation reflex inhibits the expiratory centers and stimulates the inspiratory centers when the lungs are deflating. These receptors, which are distinct from those of the inflammation reflex, are located in the alveolar walls near the alveolar capillary network. The smaller the volume of the lungs, the greater the degree of inhibition until exhalation stops and inhalation begins. This reflex normally functions only during forced exhalation when both the inspiratory and expiratory centers are active. Protective reflexes operate when you are exposed to toxic vapors, chemical irritants, and mechanical stimulation of the respiratory tract. The receptors involved are located in the epithelium of the respiratory tract. Examples of protective reflexes include sneezing, coughing, laryngeal spasms. Sneezing is triggering of an irritation of the wall of your nasal cavity. Coughing is triggered by irritation in your larynx, trachea, or bronchi, and we've discussed this earlier. Both reflexes involve apnea, a period which respiration is suspended. They are usually followed by a forceful expulsion of air intended to remove the offending stimulus. Again, we've gone over this mechanism earlier. The glottis is forcefully closed while the lungs are still relatively full. The abdominal and internal intercostal muscles then contract suddenly, creating pressure. This will blast air out of the respiratory passageways and the glottis reopens. Air leaving the larynx can travel at 160 kilometers per hour or 99 miles per hour, carrying mucus, foreign particles, and irritating gases out of the respiratory tract via the nose and the mouth. Laryngeal spasms result from the entry of chemical irritants, foreign objects, or fluids in the area around the glottis. This reflex generally closes your airway temporarily. A very strong stimulus, such as toxic gas, should close the glottis so powerful that you could lose consciousness and die without taking another breath. Fine chicken bones or fish bones that pierce the laryngeal walls can also stimulate laryngeal spasms, swelling, or both, restricting the airway. Several other sensory stimuli can affect activities in the respiratory centers. In some cases, the mechanisms involved are not known. Activity of the cerebral cortex has an indirect effect on the respiratory centers. Conscious thought processes tied strong emotions such as rage or fear affect respiratory rate by stimulating the centers of the hypothalamus. Emotional states can affect respiratory through activation of sympathetic or parasympathetic divisions of the autonomic nervous system. Again, I've alluded to these two symptoms previously, sympathetic and parasympathetic division. If there's still some confusion, I would recommend you go to your textbook and look up these two systems, sympathetic and parasympathetic nervous systems, part of the autonomic nervous system, and understand how they work. Sympathetic activation causes bronchodilation and increases the respiratory rate. The parasympathetic stimulation has the opposite effect. Again, when you think of sympathetic and parasympathetic divisions, think of the flight or fight response. The flight or fight response relates specifically to the sympathetic nervous system, where the body prepares itself to either run or to fight in an emergent situation. For us to be able to involve higher levels of skeletal muscle in this activity, it requires bronchodilation. It would involve bronchodilation, which would make more oxygen available to the skeletal muscles, increased respiratory rate, which improves and increases ventilation and exchange of O2 for CO2, thus increasing the availability of oxygen to the skeletal muscles so you can either fight or flight. Now, the parasympathetic nervous system during this period of action would obviously have the opposite effect. An anticipation of strenuous exercise can trigger an automatic increase in respiratory rate along the increased cardiac output along with increased sympathetic stimulation. Our conscious control over our respiratory activities may bypass the respiratory centers completely using pyramidal fibers that innervate the same lower motor neurons that are controlled by the DRG and the VRG. This control mechanism is an essential part of speaking, singing, swimming, and respiratory activities must be precisely timed. Higher centers can also have an inhibitory effect on the apneustic center, on the DRG and the VRG. This effect is important when you hold your breath. Our abilities to override the respiratory centers have limits, however. The chemoreceptor reflexes are extremely powerful respiratory stimulators and cannot be consciously suppressed. For example, you cannot kill yourself by holding your breath or till you turn blue. Once the once these levels, or CO2 levels, rise to critical levels, you will be forced to take a breath. The respiratory system of a fetus and that of a newborn infant differ in several important ways. You should be somewhat familiar with these ways. Before delivery, pulmonary artery resistance is high. However, the pulmonary vessels are collapsed. The rib cages are compressed, and the lungs and the conducting passageway contain only small amounts of fluid and no air. During delivery, the lungs are compressed. They're compressed further than they already were in utero, and as the placental connection is lost, blood oxygen levels fall and carbon dioxide levels climb rapidly. At birth, a newborn infant takes truly a first heroic breath through a powerful contraction of the diaphragmatic and external intercostal muscles. The inhaled air must enter the respiratory passageways with enough force to overcome surface tensions and inflate the bronchial tree and most of the alveoli. The same drop in pressure that pulls air into the lungs pulls blood into the pulmonary circulation. The changes in the blood flow that occur lead to closure of the foramen ovale, which you're already familiar with, an interatrial connection, and the ductus arteriosus, the fetal connection between the pulmonary trunk and the aorta. The exhalation that follows fails to empty the lungs completely because the rib cage does not return to its former fully compressed state. Cartilages and connective tissue keep the conducting passageways open, and surfactant covering the alveolar surfaces prevent their collapse. Subsequent breaths complete the inflammation of the alveoli. Pathologists sometimes use this physical change to determine whether a newborn infant died before delivery or shortly thereafter. Before the first breath, the lungs are completely filled with amniotic fluids, and they will sink if placed in water. After the infant's first breath, even the collapsed lungs contain enough air to keep them afloat. As one's age increases, elastic tissue deteriorates throughout the body, reducing the compliance of lungs and lowering their vital capacity. Chest movements are restricted by arthritic changes, arthritis, rheumatoid arthritis, or osteoarthritis, changes in the ribs' articulation processes, by decreased flexibility at the costal cartilages. In AMP1, we discussed the articulations of the ribs with not only the spinal column but also at the level of the sternum at the costal cartilages. The stiffening and reduction in chest movement effectively limits the respiratory minute volume. This restriction contributes to the reduction in exercise performance and the capabilities with increasing age. Some degree of emphysema is normal in individuals over 50. However, the extent varies widely with the lifetime exposure to cigarette smoke and other respiratory irritants. The relative respiratory performances of individuals who have never smoked, individuals who quit smoking at the age of 45, and individuals who quit smoking at the age of 65, and lifelong smokers is illustrated in the next slide. As you can see, this demonstrates respiratory performance based upon years of age. A person who's never smoked compared to a person who stopped smoking at a particular age. This example demonstrates the age of 45. Individuals who have continued to smoke, and then an individual that may have stopped smoking at the age of 65. A couple of things to note. Obviously, at a certain point, there is irreparable damage that has occurred in the parenchyma of the lung. And even though the individual stops smoking, he will never be able to achieve the respiratory performance that an individual that has never smoked. Additionally, a person who stops smoking after disability has occurred, such as in the case of chronic obstructive pulmonary disease or emphysema, that person will never return to a level where he would have the respiratory performance of an individual that's never smoked. You can also see the individual, even at the age of 45, that stopped smoking, still has the potential to reach a level of disability. Remember, smoking is not necessarily dose dependent. Different individuals that smoke a different amount of cigarettes can be affected in either of these growth curves. So it's not always based upon the pack years, the number of cigarettes you smoke on a daily basis, calculated over a year period of time. Emphysema and lung cancer. Emphysema and lung cancer are two relatively common disorders that are often associated with cigarette smoking. Emphysema is a chronic progressive condition characterized by shortness of breath and the inability to tolerate physical exertion. The underlying problem is the destruction of the alveolar surfaces and inadequate surface areas for oxygen and carbon dioxide exchange. In essence, respiratory bronchioles and alveoli are functionally eliminated. The alveoli gradually expand and the adjacent alveoli merge to form larger air spaces supported by fibrous tissue without alveolar capillary network. As connective tissues are eliminated, compliance increases, air movement into and out of lungs more easily than before. However, the loss of respiratory surface area restricts oxygen absorption, so individuals become short of breath. Emphysema has been linked to inhalation of air that contains fine particulate matter or toxic vapors such as cigarette smoke. Genetic factors also predispose individuals to these conditions. Some degree of emphysema is normal consequences of aging. However, estimated that 66% of adult males and 25% of adult females have detectable areas of emphysema in their lungs. Lung cancer, or pleuropulmonary neoplasm, is an aggressive class of malignancy originating from the bronchial passageways or alveoli. These cancers affect the epithelial cells that line the conductive passageways, mucus glands, or alveoli. Symptoms generally do not appear until the condition has progressed to a point at which tumor masses are restricting airflow or compressing adjacent structures. Chest pain, shortness of breath, a cough or a wheeze, and weight loss are common symptoms. Treatment programs vary with the cellular organization of the tumor and where the metastasis, cancer cell migration, has occurred, but surgery, radiation exposure, and chemotherapy may be involved. Deaths from lung cancers were rare at the turn of the 20th century, but 29,000 such deaths occurred in 1956, 105,000 in 1978, 154,900 in 2002, and it's estimated in 2005 this number will be over 175,000 individuals in the United States. The rise coincides with the increased rate of smoking in the population. The number of diagnosed cases is also rising, doubling 15 years. Each year, 22% of new cancers detected are lung cancers in the United States. In 2002, it was estimated that 90,200 men and 79,200 women will be diagnosed with this condition. It is estimated in 2005 that these numbers will both break over 100,000. Lung cancer increasingly marked among women, but declining among men since 1989. 101,000 men and 54,000 women were diagnosed with lung cancer in the United States. The goal of respiratory activity is to maintain homeostatic oxygen and carbon dioxide level in peripheral tissue. Changes in the respiratory activity alone was seldom sufficient to accomplish this, and there must be also coordinated changes in the cardiac or cardiovascular activity. At a local level, changes in the lung perfusion in response to changes in the alveoli improve the efficiency of the gas exchange within and among the lobules. Chemoreceptor stimulation not only increases the respiratory drive, it also causes elevation in blood pressure and increased cardiac output. You can see now why I spend a significant amount of time on the cardiovascular system and the pulmonary system. It's the integration of these two systems are ultimately essential to the correct functioning and homeostasis of the body. The stimulation of baroreceptors in the lungs has a secondary effect on the cardiovascular function. For example, the stimulation of airway stretch receptors not only triggers inflammation reflex, but also increases the heart rate. Thus, as lungs fill, cardiac output rises and more blood flow through the alveolar capillaries. These are the primary organs of the respiratory center. You should recognize them and be able to identify the primary functions. This table is taken from your textbook, gives primary functions of nasal cavity, paranasal sinuses, pharynx, larynx, trachea, bronchi, lungs, and the alveoli. This concludes a lecture on the respiratory system. The next series of lectures will involve the circulatory system and the lymphatic system.